So I was looking on Facebook one day and I saw this post, and it said, the first wave of what will eventually be a tsunami of lawsuits against dentists who placed all-ons are hitting the beach. Your intuition was correct about cleansability being an issue, therefore so was Carl Misch. The all-on trend is being driven primarily by greed and efficiencies that have evolved within the digital world, not because they are always the best decision. Making matters worse, the all-on process has been industrialized and deployed with sophisticated marketing strategies to draw people into a teeth-in-a-day solution that has some significant potential downsides. The tail has started to wag the dog. And what I would like to say is, again, as a prosthodontist, I get to see some of the worst of the worst. And so here's a patient that came in, spent $35,000 on a prosthesis, immediate load prosthesis, and when he came in, he was taking this in and out of his sockets, okay? And this is, just your typical example of not thinking about the person first, not working up the case to create an individual treatment plan for a patient, not maybe doing virtual treatment planning and analyzing the restorative space, skipping all those steps that I talked about earlier. And that email.
There's that, and then these patients want this, they want it yesterday, they want it next week. And,
Yep.
And I have it by Christmas.
Uh-huh.
You get this every year.
Oh, yeah.
My teeth gonna be done by Christmas?
Mm-hmm.
And that's what drives a lot of this too, is the patient themselves.
Yeah, I mean, if you're going to do these full arch restorations, whether it's screw retained or it's locator fixed, you really do have to create a protocol that you stick to, for every patient.
Well, I just find it easier every year to put the brakes on the patient. It's just, the answer now is no. It's not going to be ready by Christmas.
Right.
Right.
I agree 100%.
Yeah, because when you have to redo one or two of these, it's quickly not worth it.
But, so just to contrast, I've done, over the last 15 years, approximately 750 full arch cases between screw retained, locator fixed. And if I only was able to do one thing for the rest of my career, this is what I would do, because of the satisfaction and the changing of the life that these people have when you do it correctly. But conversely, these people, some people, take their entire life savings because their lives are miserable because of their relationships, their job. They want to fix their teeth. They want to smile. They want to be able to eat again. And to think that a dentist could do this and just skip steps and not care about the final result, leads to these kind of posts like this. Because really, like I've talked about, the restorative space is so important. Having enough bone reduction so that you can create a flat surface, have a flat intaglio. But unfortunately, I'm starting to see, like, even from some of the corporate centers that, they go hunting for these patients. They're not, every patient that goes into them, that's what they're going to get. They're hunting for these patients. They're pushing them into these treatments. They're not doing individualized treatment planning. Or on the other side, you get somebody that will just go to a weekend course and decide they're going to do it all. They're going to do the surgery. They're going to do the prosthetics. And there are some people that are good enough to do that, but they're very far and few between. I am not good enough to do it all. And I find great comfort working as a part of an interdisciplinary team and having this surgeon knows the anatomy, has been through all the training, seen it all, and I do the restorative. And having a very good lab that's going to know the biology and know what we're looking for. So if you're just getting into this, my suggestion is follow all the rules. Do this risk assessment. your first couple cases should probably be analog, so you can get a feel for what you then can do, can do digitally. Because like I said, it's, these patients, these 750 patients are my favorite patients. They think I'm a god. They're the ones that send their family. Like, I get so many referrals from these patients when you do do them right and change their lives. So there's a big commitment to doing these kind of cases. And the reason that a lot of people get into trouble is because they skip all this other stuff. And a typical scenario, like a surgeon sometimes, they'll take an x-ray, or even a general dentist, or even probably some prosthodontists too. They look at the level of atrophy, they look at the quality of the bone, they look at the anatomy, they look at the patient's medical history, they want to do a full arch restoration, and so they say, okay, let's take your teeth out, and they just go into it without doing this thorough workup. But they haven't asked the question, has this high smile line been determined? Will a flangeless prosthesis give the patient enough lip support? Does the patient have parafunctional habits that could cause the failure in the surgical phase, or should they get some Botox to decrease the pressure of their muscles? Will the incisal edge position and the midline be changed? Has the patient been given all of the treatment options and talked about the advantages and disadvantages? Will the vertical dimension be opened? We don't want to leave this all up to the lab. We want to do these things ourselves. Here's a gentleman that came in, and this is what we talk about when we talk about the transition line and planning the case so that we remove enough bone so that when the patient talks and smiles, they're not going to see the junction of the prosthesis to the upper lip. His chief complaint was that my lip gets stuck on my teeth, food sticks to the edge of the little platform. My friends look at me funny when I'm talking to them. This is a disaster when this happens, because there's the only choice is to fix it are either remove the implants, do more bone reduction and place additional implants, or get Botox injections every 6 months because they don't last forever. I've seen some patients that have these little bumpers that they put in to hide that, but I mean that's miserable. So these are the things that I want to caution you about. And I was able to get his previous records, and I could see how someone could make a mistake if they let's say they don't take any photos, or maybe they just took a picture of the patient like this and didn't have him with a full smile, because when he has a full smile, that's what he looked like. So there's no way that you could use those implants and make a successful final restoration without planning to take away a lot of bone before you place the implants. This is what we call an FP1 type of a immediate load prosthesis. And on these FP1s where we don't have pink, it even becomes more important to plan the implants in the proper vertical height and the proper position underneath a tooth, because you start to see things like tooth proportions are wrong, the laterals are higher than the centrals. This is a surgical appliance. You can see that the implant is in the embrasure. For these kind of cases, you got to have the implant in the exact place, or these things are going to look, they're not going to look correct. So just again, a result of improper planning.